Good evening, everyone. Thank you and gratitude to all the members and the organizers of the midterm Dehradun AIOC. My topic is patient selection and calculations for the toric IOL. As we know that the toric IOL practice has in the recent years has increased, and the modern day cataract surgery is a refractive surgery. So precise planning is the most important factor here. Toric calculations, once done well, the results are very gratifying and we have happy patients. So an ideal case selection is prerequisite before the surgery to ensure patient satisfaction and to give optimal outcome. Ideally, a patient for toric is where the vision is compromised by cataract, he has regular astigmatism, and there are no major ocular comorbidities. That is, any case where we can do phacoemulsification is our patient for toric IOL. So here we are killing two birds with one arrow. We are treating cataract as well as astigmatism. Absolute contraindications would be irregular astigmatism, zonular instability, some complications with the capsule while operating if we have a tear. So we definitely need a stable capsular back complex for the rotational stability of the IOL. Relative contraindications would be poorly dilating pupil. These surgeons are now highly skilled in even doing mid-dilated pupils also, but we can also use the dilating devices like the BHEX, the maluing rings, or the iris hooks. Then the other contraindications are patients undergoing the VR procedures, any glaucoma surgeries. So any patient where the vision is compromised as well as the macula, if the vision improves more than 624, we can still consider to do a toric IOL. Patients with progressive fleshy pterygiums need to be operated first, and then we can wait for 6 to 8 weeks to go in for a cataract with toric. And now the other contraindications, the keratoconus, Fuchs dystrophy, corneal scars. Also, we need to give some time to the patient and see him on the slit lamp for a while to rule out dry eyes, any ocular surface disorders, and other meibomian gland disorders too. So the indications is regular astigmatism where two principal meridians are 90 degrees to each other and the cornea is uniform. Patient counseling here is again very important. Patient's expectation is a subjective factor. We should understand what the patient needs, what his profession is, what his hobbies are, as well as the patient needs to know what is the outcome after his surgery. So any unrealistic expectations should be dealt now. Patient needs to be educated about astigmatism, about what is toric IOL, how it is different from a regular monofocal IOL. And also, if we are planning a monofocal toric, then he needs to be understood that he will need near vision correction. And if he is wishing to have a spectacle-free life after surgery, we need to counsel him for a multifocal or a trifocal toric lens. So the lenses available, they are from 0.75 to 4.75, which will correct sphericity from 6 to 34 diopters. We also have extended series and customized toric IOLs for higher power. Ultima Smart is one of them, which makes for us. So the first test before for evaluation after we have done the external examination and the fundoscopy would be keratometry. We all know that total dioptric power of the eye is cornea plus the lens. Here the lens is the cataractus, so we need to know our anterior as well as our posterior corneal measurements. Multiple measurements should be done by separate devices based on the different principles, and these could be manual keratometer, automated keratometer, Placido-based corneal topographer, shuntling, imaging system, and OCT-based system. If there is any variability between both the devices, we have to evaluate for coexisting ocular morbidity. So we have the anterior cornea and the posterior cornea. Now we know that the posterior cornea also acts as a concave lens, and it gives us some amount of steepness, about 0.5. Anterior cornea with the rule astigmatism in younger people can shift against the rule astigmatism in older people. And so if we do not take in consideration of the posterior cornea, we are going to be having a lot of surprises after the surgery. We can have increase with the rule astigmatism and decrease in after the rule astigmatism. So both anterior and the posterior cornea measurements nowadays can be done in most of the latest biometers, and these ideal formula, they will include the SIA, the posterior corneal curvature, and the effective lens position. The SIA is, most of us know our SIA, and it is the amount of astigmatism that we will be leaving after the surgery. And usually in the micro-incisional cataract surgery that we do nowadays, it's about 0.1 to 0.2, or we can go ahead and calculate it on this website, that is crcalculator.com. So basically, the Barrack toric calculator is the what everybody needs to know now, and it uses a universal 2 formula, and it has a I think Dr. Richa has also said about this. It considers axial length, keratometry, ACD, lens thickness, and white to white. Also, it is freely available on the ASCRS website, where we can just go and fill in the data, the patient's data, the steep and the flat axis, and we can get our axis of alignment. And this is also available with various companies, the individual IOLs that we are using. So this can be easily done. Image guided system is a Virion and the Callisto that can be used for preoperative planning, which will give us the location and the size of the surgical incision as well as IOL positioning. Then we have the iTrace, which combines the placido-disc corneal topography, and it will help us with preoperative as well as postoperative assessment in cases undergoing IOL implantation. It also has an inbuilt toric planner, and it helps us to calculate the power. So take-home message would be reduction in astigmatism is critically important because it can result in significant improvement in visual acuity. But educating patients with astigmatism is important. My talk is on patient selection. So we have to utilize some patient educational material like some brochures or vision images. And lastly, implanting a toric IOL is an art, and we surgeons are the artists. Thank you for the patient hearing.
Any questions from the house? Sir.
In the toric IOL, 2 errors are there, which we are not even able to predict. One is SIA, and second is PCA. So, how much is the PCA? Though we are using that Barrack nomogram, these formulas are integrated in that formula, Barrack toric calculator, but still, their measured PCA is something different, and so these are the 2 errors.
Yes. So, as it is a lot of experience, I think that goes in hand, and most important thing is after the calculations are done properly is also the way we've implanted the lens. I mean, making a good capsular axis is also important so that it covers 360 degrees the IOL. Washing out the OVD is another step to do, and maintaining a good anterior chamber depth till the end.
So for SIA, just I want to say a few words. Incision SIA, we can't predict because when we take incisional temporal incision, either the axis will rotate or the flattening or steepening of the cornea will occur. So we can't predict it. So Dr. Barrack, he's saying that don't increase the size of incision, go for 2.4 or less than that, and take the incision SIA value 0.1 for incision. Go for a smaller incision and take the value of 0.1. So for incision SIA or 0.2.
Nice presentation. I just want to highlight sometimes if you have a few 2 or 3 devices and your keratometry readings are not matching, then it will be a better idea to defer the toric IOL, or you go into the Barrack formula and there is a total K. So it has a provision, you put in all the readings and it gives you an average K, but still you are not sure that the patient is going to benefit from the toric IOL. Other thing is the contraindications which you talked about, ma'am. I think so small pupil you can do toric IOLs, but it's a relative contraindication. The only problem you have with small pupils is that you might have a problem in aligning the IOL. Otherwise you can do it. And keratoconus, I am not a cornea surgeon, but a lot of them say that if the keratoconus is stable for the last say 1 year, you can go ahead and do a toric IOL once you have done a C3R. But I don't know if you can
If the patient is using spectacles, a keratoconus patient, and he's stable and he's happy with the spectacles, he might be happy with the lenses as well. If
Can you submit again?
Saying is there a problem if the patient has asteroid
if the vision you think can improve more than, if you can give him that quality of vision more than say 624, then you should go for it.
toric IOLs are not as notorious as multifocal IOLs. So even the toric IOL is forgiving. Even if you will implant a toric IOL, it won't matter much. But multifocal IOLs, asteroid hyalosis, if you are doing a multifocal toric, don't do it with asteroid hyalosis.
Yeah, and if you're doing a multifocal, then even a small error should be corrected and multifocal toric should be implanted, because then the patient will not be happy. He's going to be paying a big amount for your multifocal lenses.
I have a question from the panelists. So what are your cutoff values for the amount of astigmatism when you're planning a premium IOL surgery for choosing a toric IOL? Like for how much astigmatism would you plan a premium, like a multifocal or an EDOF IOL? Would you plan a toric one versus a non-toric?
It actually depends upon what astigmatism you are dealing with. If you are dealing with the rule astigmatism, you can up your threshold, what the Baylor
So
norm.
how much would you?
We do toric IOLs after one diopter of astigmatism. If you are say having astigmatism of 0.6 against the rule, you add a 0.5 so it goes to more than 1, so you do a toric IOL. If you are having a with the rule say 1.5 or 1.2, subtract the against the rule posterior. So you can go and just give the incision in the steep axis and you can get away. So it depends upon what you are dealing with. If you are dealing with the rule, you may up your threshold to 1.5 say. If you are doing against the rule, bring it down to 0.7. So it all depends what anterior astigmatism.
Most of the cataract patients will have ATR, so
Enter your
even
data.
if you're planning a trifocal or a multifocal, better even if you have a 0.75, you should do a toric.
The easiest option is once you know that you're going to insert incision wherever you're going to take, put it on the toric calculator. You're suggesting a toric
Enter your data in the Barrett toric calculator. Net astigmatism is written there. last.
Basically,
So it is
threshold.
more than 1, then you can go. If it is less than 1 and it is against the rule, you can take 2.8 millimeter incision. It will decrease some to 0.234 diopter. So it's okay.
The threshold has to be lower when
on
you're
your
using a
mercy.
premium lens like a EDOF or multifocal. If it's a monofocal, you can probably stretch it to 1.5 or more. But for these, because you want to deliver an uncorrected vision, your threshold has to be low. Yeah. Another point for keratoconus, you were talking. In keratoconus patients, you can certainly use toric lenses, but you have to look at the topography. Make sure it's largely regular and the Mayas are not greatly skewed. If it's very skewed, then you can get an unpredictable result. So look at that, and if you've got one of the advanced topographers, you can look at EKR map and all that.
You are doing serial topographies
Yes.
before you decide.
And of course, it should be stabilized by cross-linking or natural stabilization. And formula-wise, K in keratoconus formula is the only specific formula for keratoconus. Otherwise, SRKT is the other one which works reasonably well in keratoconic patients.